Now we come to the section that examines the different conduction abnormalities that occur in association with some sort of change in the atrioventricular node. AV block is basically going to happen due to a couple of different things. AV block is basically a delay or interruption in the conductance, either temporary or permanent, due to molecular, anatomic, or functional problems. The conduction can be slowed down, occur in intermittent bursts, or remain constantly absent. A quick summary is that in first degree block, you just have decreased conductance. Second degree is a continuation of this decreased conductance to eventually where you lose impulse propagation. And third degree block is there is no propagation and no conductance at all through the AV node. So the AV node is not propagating anything between the atria and the ventricles in any sort of way in third degree block. Let's start with first degree AV block. The PR interval is prolonged, but the patient is usually asymptomatic. Okay, great. What does that even mean to us? Well, think back when we discussed the PR interval. It is from the onset of the P wave to the onset of the QRS complex, or essentially the R wave. Now, essentially, that means it includes everything that happens from the beginning of atrial depolarization to the moment when the ventricular myocytes are just about to be depolarized and contract. So this means that it reflects conductance through the atria, the AV node, the His bundle, or the common bundle, the bundle branches, and the Purkinje system. You do not include ventricular contraction because this actually means that the EKG electrodes would be reading the depolarization of the individual myocytes in the ventricles, because that electrical vector that is created by the depolarization of the ventricular myocytes occurs after they have been stimulated by the Purkinje fibers, and it shows as your QRS complex. The Purkinje fibers are just a conductive tissue that sets the depolarization of each individual myocyte. Remember, myocytes are all connected by gap junctions, so all of this happens rather quickly. Decreased conductance due to ionic abnormalities or anatomic impairments in any of the structures from the atria to the Purkinje fibers can actually prolong your PR interval. Most of the time, it is a problem with the AV node. It is usually due to excessive vagal stimulation, beta receptor or calcium channel blockade. So if we increase our vagal stimulation or block beta or calcium channels, we can decrease the conductivity of the AV node. Remember, the AV node is a pacemaker cell and is dependent on calcium conductance for depolarization. Now, why these conductance problems can occur with those we will talk about in a second. You can also have some infiltration of the AV node from amyloid and sarcoid that will also cause structural abnormalities of the AV node. So how do all of these affect the AV node? Well, excessive vagal stimulation and beta antagonism both decrease L-type calcium channel current as well as calcium channel block. By directly blocking calcium current through the channels with a calcium channel blocker, you have the similar effects. Whenever you decrease the intracellular calcium, this causes a decrease in the conductivity of those AV nodal cells because they rely on calcium for their depolarization rate. So now, if you examine the ECG tracing, you can see that the PR interval is actually prolonged. If you count the boxes, one box is 40 milliseconds, and the normal PR interval is supposed to be under 200 milliseconds. So if you count more than 5 boxes, bam, you know something's up. Well, see, here we have 1 box, 2 box, 3 box, 4 box, 5 boxes. So we're right at that threshold where we know something could be going on. I seriously doubt you will have to count any boxes on your step 1 exam. And by seriously doubt, I mean I can pretty much guarantee you will not be counting boxes. That's what cardiologists do and machines do, not students taking their step 1 exam. Step 1 examiners should give you a vignette and then tell you that the PR interval is prolonged, in addition to maybe showing you a tracing. So again, for AV block, it can be due to amyloidosis, sarcoidosis, increased vagal stimulation, beta blockade, or calcium channel blockade. All of these decrease the ability of the AV node to conduct, and we all know that the AV node, just like the SA node, is dependent on calcium conductance for its depolarization phase. So we started with the mildest form of AV block, which is first degree. Now let's take it up a notch and discuss some second degree block. So we went from first degree to second degree. What does that mean to us? Well, that's a very helpful way for me to think about the differences between all of the AV blocks. So we went from 1 to 2. Then you must have increased in severity of the dysfunction or pathology in the AV node. Second degree block is also named Mobitz type 1 or Wenke block. Kind of confusing, right? We have to know what it is, then we have to memorize 3 different ways to call it. Yep, unfortunately not much to do here, but to remember the name, but we can understand the pathology. So what is going on in the second degree AV block, Mobitz type 1 block, or Wenke block? The ability of the AV node to conduct the impulse from the atria will gradually decrease. So it gets worse and worse until eventually you completely lose the ability to conduct the electrical signal from the atria to the ventricles. This is often described as having an increased PR interval until you drop a beat. Remember, the PR interval represents all the structures from the AV node to the Purkinje system, and it usually has some pathology to do with the AV node when it's on your exam. The term dropping a beat doesn't mean that you're rapping or anything. It indicates that you do not have a QRS complex after a P wave. There is no QRS. You will just have a P wave, and then you'll have another P wave because you dropped that QRS beat or complex. So you do not have a QRS complex to accompany the atrial depolarization that is represented by your P wave. I like to make a simple analogy in my head that Mobitz and Wenke block, these are two scientists together. They eventually grew apart slowly, which means that they increased the PR interval between themselves until eventually Mobitz dropped a beat or Bach. And now all you're left with is Mobitz by himself, which in my head is Mobitz type 1. I don't know if that makes sense for you guys, but that's a great way that I remember it. Kind of an elaborate way to remember something, but anything goes during step 1 preparation. So as you can see here, in your lead V1, these PR intervals are very small and hard to see, and your P wave is inverted because in V1 is one of the precordial leads, and the P wave is going away from the positive electrode of V1, so that is why the wave is inverted. They're gradually getting longer. Very hard to see here, but as you can tell, this one is longer than the previous, this one is slightly longer than the previous, until eventually we have a P wave and then there's no QRS complex. Do you see how the PR intervals are getting larger until eventually we have a P wave that has nothing following it? Okay, great. Quick summary of what we have learned so far. All blocks are problems with somewhere from the atria to the Purkinje system, but most of the time it's within the AV node. Hence the term first, second degree, and third degree AV node block. First degree block is an increased PR interval because something is delaying the conduction through the AV node. Most of the time this is due to increased vagal stimulation, beta or calcium receptor or channel blockade. It can be due to amyloid or sarcoid. The second degree block is a gradually increasing PR interval until eventually we do not have a P wave followed by a QRS complex. The AV node is really struggling here. So not only will it have slow conductance compared to normal, it will have an increased PR intervals until eventually the AV node just fails to send the signal from the atria to the ventricles, which means we do not depolarize our ventricular myocytes and we do not get that mean electrical vector that represents our QRS complex on the ECG tracing. We just discussed that Mobitz type 1 was prolongation of the PR interval successively until we didn't conduct the atrial impulse into the ventricles, which means that we dropped a beat or a QRS complex was not directly following a P wave on our ECG tracings. Now we're at Mobitz type 2, not Wenke block. The difference between type 1 and type 2 is what? Well, in type 2, there is no PR prolongation. If you look at this ECG tracing, there's a dropped beat without any change in the PR interval. So here, P wave, no QRS complex, these are QRS complexes. There was no change in the P wave, and as you can see, there's no change in the P wave here. Remember, drop beat refers to the absence of the QRS complex, which we would expect to have right here, but we don't, and we expect to have right here, but we don't. Type 2 Mobitz is usually caused by fibrotic changes in the conductive system immediately under the AV node. So remember, under the AV node we have the bundle of His. And then we have the bundle of His, which is the common bundle, splitting into the left bundle branch and the right bundle branch. So it can be fibrotic changes here, or fibrotic changes here, or here. There is usually not a problem with the AV node, despite the name of second degree AV block, which is the reason why there's no change in the PR interval